Good morning.
Good morning.
How are you?
I'm excellent. Thank you.
Thank you very much for agreeing to talk to me. And for anybody out there who doesn't recognise Dr. Tazbirkova, she is an oncologist, and we work together at both John Flynn and Pindara Hospital. And so we obviously have a very active oncology service at both of the hospitals. And in ED, therefore, we do occasionally end up interacting with you guys. And the thing that I've noticed most over the last few years is there's really been an evolution of treatments for, I guess, in your specialty. And what I'm seeing more of is the more immunotherapy type options. Mm-hmm. And I guess that I feel like I've got relatively well practiced at managing neutropenic sepsis, and now we've got this whole different spectrum of conditions and complications that we may see with the immunotherapy, and I feel like I haven't really quite kept up with it. So I was hoping to quiz you on, well, not quiz you, I don't want you to be too anxious, they're not very difficult questions, but would you mind if I just picked your brains about this?
Not at all.
Okay.
Very happy to answer any questions, and thank you for having me.
Yeah, it's a pleasure.
Giving the opportunity to, give a bit of an update, or go through some queries that you might have.
So could I start by asking, and again, this doesn't have to be a definitive textbook list, but what are the conditions that you would more commonly be using immunotherapy type agents for these days, Andrew?
So the simple answer to it is pretty much every cancer can now be treated with immunotherapy. So we've been gradually over the past couple of decades, we've been trying to find a role for immunotherapy in almost all conditions.
Yeah, okay.
The most frequently treated ones where we use immunotherapy pretty much all the time would be melanoma and lung cancer. So
right.
They are the two big tumor groups that are almost always treated with immunotherapy. So for example, patients with metastatic melanoma, we only use immunotherapy these days. So they are the group that we've seen the major improvement in outcomes of these patients. So we all know that patients with stage 4 or incurable melanomas would have outlooks in a vicinity of 3 to 6 months in about 10 years ago. But with the introduction of immunotherapy, we have these patients living past 5 years, and it's a significant proportion. So over 50% of patients with incurable melanoma are now living past 5 years as a result of these treatments.
I've noticed that because, again, in my, I guess, relatively short career, melanoma used to be just a nightmare, history basically. And now we're seeing people who've had melanoma and they often are
cancer-free for a long period of time. So a third of patients would be in remission past 5 years. So we think we are starting to be very optimistic and starting to believe we can potentially cure an incurable cancer, but we obviously still need longer term follow-up for that. So as a result of that, we are seeing more melanoma patients because they live longer, they are treated for a longer period of time. So you will probably be seeing more melanoma patients. Equally so, the metastatic lung cancer, immunotherapy is built into their regimens as well. But we've been using immunotherapy for bladder cancers, kidney cancers, head and neck, non-melanoma skin cancers, but starting to even introduce to cancers that have been initially thought to be quite resistant to immunotherapy, such as breast cancer and prostate cancer. So we are finding ways of sort of building them into the treatment schedule.
Yeah, okay. And so I don't have any idea how it works.
It is very
Is
very
there a
different.
simple explanation for me?
Oh, we can try. So it is a very different principle to chemotherapy.
Yeah.
So chemotherapy drugs get given as an intravenous or oral drug, get into the bloodstream and hit the cancer directly. So it's actually the drug that's killing the cancer.
Yeah.
Whereas immunotherapy is using our own immune system to fight, so to do the job. So immunotherapy drugs don't actually kill the cancer directly. What they do, they help the immune system to recognize that cancer is something that's not meant to be in our bodies, and it attacks it.
Yeah.
So the reason why our cancer is happily growing in our bodies is that the immune system is being kind of tricked. The cancer has ability to camouflage itself by producing chemicals that send a sort of a peace signal to the immune system, saying, leave me alone, I'm the good guy, I'm just going to happily grow here. And the immune system believes that signal and it backs off and leaves the cancer alone. What immunotherapy drugs do, they actually get rid of that peace signal, so they unmask the cancer. The immune system starts to recognize that the cancer is not meant to be in our bodies, and it goes in and attacks it. So it's a very simple way of putting it.
So does that mean for every specific type of cancer there is a different immunological agent that's will attach to those cancer cells? Or?
No, it's basically working on interrupting the chemical interaction between cancers and immune systems. That interaction is the same for all cancers. The differences are that some cancers communicating with the immune system a bit more, and they obviously would be more affected by immunotherapy. Other cancers are not so much dependent on the immune system control, and they are the ones that are a bit more resistant to the treatment. So the area where the signal gets interrupted by the drug is the same for all different types of cancers. So we have different drugs that act on different signals, but they would be identical for all cancers.
Okay, cool. And so now I feel like the spectrum of complications is and I guess not everybody gets complications. I don't want to make it seem like that, but I kind of end up getting involved when there's maybe been a complication. People are particularly unwell. So are there a particular group of complications that you might expect to see with these immuno agents that me and my emergency colleagues might need to look out for?
So the complications again are the results of the mechanism of the way the drugs work. So because they overstimulate the immune system, so the immune system gets a bit too excited, too active, and it goes in, attacks the cancer. But as a collateral damage, it can sometimes attack parts of our body, so normal organs, and that can essentially be any part of our body. So it causes immune mediated or inflammatory reaction in any organ. So the most common organs are skin, bowels, lungs, and liver. They are the most common side effects we see. So as a result of that, we see rash, dermatitis, even just itch, dry, itchy skin, hepatitis, pneumonitis, and colitis. So they are probably the most common ones that you would encounter in emergency or in a deteriorating patient in the ward. But there can be, for example, endocrine complications such as thyroiditis or even hypophysitis. So inflammation of thyroid or pituitary gland that are often a bit more delayed side effects, and they can often be picked up on a blood test that we do as a routine screening in the clinic, and they can be managed as a patient. So majority of patients on immunotherapy actually don't have any side effects. So often benefit of these treatments are that patients almost don't even know they are having any treatment. They have good quality of life. They rarely have any side effects. But if they develop side effects, they do have to be very well educated that they are not So for example, if they develop a diarrhea, they are not to just sit at home and take a couple of gastrostop and watch it. They need to notify us, and I guess the same applies to you. So if a patient presents with diarrhea, we have to have a high level of suspicion that it could be an immune-mediated colitis, and that perhaps a treatment based on that would need to be initiated.
Because I feel like we've got quite well practiced at, I mean, the majority of the more serious complications we see from chemotherapy are more related to the neutropenia and the infections. And so, and it's only recently that and patients sometimes don't really know that they're on immunotherapy versus chemotherapy, or they tell us they're having chemotherapy. So, we might see a patient with a cough and shortness of breath and maybe even a temperature, and those things can be a pneumonitis
or infection
with an inflammatory response to that, or infection. So it's all of a sudden my head is started to spin a little bit. And so do you see as many actual infective complications with the immunotherapy, or does it not tend to affect you?
So immunotherapy in principle does not cause immunosuppression, so patients should not get immunosuppressed as a result of the treatment. I guess if you do have patients with fevers and either diarrhea or respiratory symptoms, the rule of thumb is always consider the most common causes first. So we still need to rule out infection. So your workout or septic workout for anyone with fever would be totally appropriate. So you still, do your cultures, do your bloods and imaging of the appropriate part of the body. But that would be the most common cause of fever. So we don't routinely see fevers just as a result of treatment or immune response. So fevers always have to result in suspicious and investigations of infection. I think the difference is that it may not be classed as a medical emergency as if it would be in severely neutropenic patients. So we don't have to really start broad spectrum antibiotics up front. We can wait for cultures or results of the test, providing the patient is stable. And then fine-tune the treatment down the track. Obviously, if they are unwell, septic, they need treatment as per any sort of severe infection. So it can get a bit more complicated because often patients, and the majority of patients, for example, with metastatic lung cancer, will be on a combination. So they often have chemotherapy plus immunotherapy. That is a standard treatment for them. So they can be immunocompromised, they can be neutropenic, and they can be susceptible to immune-mediated complications of the immunotherapy. So just to stir it up, it can be a little bit of both. And I think really need to think about the most common cause first, have the most, I would say, sinister or dangerous complication in mind, and possibly, depending on severity of the symptoms, we may need to cover all possibilities. So we may need to start broad spectrum antibiotics, we may need to start high dose steroids for suspected immune-mediated
So I was going to say that next, that I guess the ED principles is we always assume it's the worst, and neutropenic sepsis is usually the worst, and we work back from there.
That's right,
So it sounds to me like our usual approach, where we just collect all of the cultures,
it should still be
the same basic principle. It's just that we maybe have to keep an open mind, or open our minds to the fact that it could actually be one of the inflammatory complications. And I guess the thing about that is the treatment for that might include steroids. Okay.
And again, I think we do tend to have a low threshold. Even if they're suspicious for infection, we often just start the steroids. They can hardly cause a lot of harm. I think we have low threshold for starting the steroids. Because with most complications, if they are severe enough for patients to present to hospital, they can deteriorate very quickly.
Yeah,
so
okay.
we need to withhold the drug and start steroids quite promptly.
Yeah, okay. Cool. So that's really cleared a few things up in my mind, and I think that I mean, we're very lucky here, because I know that if I'm a bit confused about this, I can just call you, and you'll have the answers as to what they're on. And so we don't have to work in the dark, and that communication is really important, and we're lucky that we can do that with you. So that's good.
And I think in terms of the workup, also predominantly for respiratory symptoms, sort of traditional imaging would be just a plain chest X-ray, or heart pneumonia, or sort of things that would be obvious on plain X-ray imaging. I think in if there's patient on immunotherapy, again, I would not hesitate to step up to a CT. Because there can be often very subtle ground glass opacities that are typical for pneumonitis that may not be obvious on the chest X-ray, and sort of that may clarify things again a bit more at the time of.
But again, as an extension to that, in my experience, you've got a patient who's got a malignant process going on, which means that increases their chance of having a PE, for example. So when they're coming in short of breath, low grade fever, we're often thinking about PE anyway. And so when we do that scan, then what you're saying is that gives us great information about whether you've got a pneumonitis as opposed to a consolidative process.
Exactly. The differential is really, really broad, and you have to really think of every possibility. Treatment-related complications, malignancy-related complications, so it can be lymphangitis or progressive disease that often we have to think about as well. That can be associated with same symptoms, sometimes fever as well. The typical infection or thromboembolic event, as you say correctly. So I think having more detailed imaging does
it can be helpful
in the differential.
Okay, good, because again, we need to be clear that Andrew is not saying that we have to CT scan everybody's chest. And I feel that I end up scanning a lot of people for a lot of things these days. So, but I feel like I'm generally justified, and it sounds like I am. Sorry to our colleagues in radiology, we're making more work for you, but we do get good information.
Common sense has to be there. So if it's a patient that's been on the ward and has constantly, is deteriorating, has got worsening breathlessness, I had CT scan the day before, we wouldn't rush in unless it's significant deteration. We wouldn't rush and do another one. So knowing a little bit what happened before
is helpful.
Before that actual event is helpful.
Sometimes we do take a history as well, occasionally, not very often, but anyway, in the interest of time, and I'm just conscious that I'm keeping you and you've got lots of work to do, but I just wanted to give you an opportunity to, if there's anything else that you think that I might or my colleagues might need to know about immunotherapy, that you're desperate to tell us, or if there's something that you notice that we're tending to stuff up frequently or that we're not doing that you'd like us to do, this is your opportunity. So is there anything that springs to mind?
No, I think as you said before, we are lucky we have a really good relationship, and the communication is important. So yes, running the initial tests that you think are appropriate, and then communicating with us is the right way to go. We both teams have a little bit to add to the patient's care, and I think that's the ultimate goal, is to put it all together. So in terms of more information, there is an enormous amount of information about immunotherapy. It's really a field that's rapidly evolving. There will be new drugs that are still in a clinical trial setting that will be more available, will be associated with more side effects, new ways of managing. So it will get more complicated, and I'm very happy to sit down with you again. And
we might have to do this in a year's time, and it will have all changed again.
I think I did mention it's partly related to immunotherapies. A lot of these agents are now kind of being used in the setting of clinical trials, and with us having quite active clinical trials units both here and at John Flynn, you will probably have patients that are on a trial. The only difference with trial patients is we do have to immediately report back about their admission. So really, the sooner we know about patients being admitted and knowing sort of as much as we can, and reporting back to the trial, the time is crucial in that situation.
Yeah, I'd never actually thought about that. That's probably really relevant. So as much information as we can.
That's right, yeah.
All right, well, I'm going to end this now. Thank you very much. Thank you for your time. Really appreciate it. And we'll maybe have to catch up again so you can give us an update. All right, thank you very much.
Thank you.